Stones in the gallbladder or cholelithiasis is one of the most common disorders afflicting the gallbladder both in males and females, usually in the middle age group. So cholelithiasis is a common biliary pathology, affects 10 to 15% of the Western population, and majority of them are asymptomatic. It is an important point to remember because every patient who develops gallbladder stone does not require surgery. So what is the etiology of gallbladder stones? So there can be some problem related to the gallbladder function, or there can be some factors associated with the cholesterol nucleation. Then there can be reasons for supersaturated bile, and fourth one is some defect with the absorption of bile acids which are required to keep the cholesterol in non-stone forming state. So first one is gallbladder defective emptying, absorption or excretion of bile can lead to the formation of stone. Second one is cholesterol nucleating factors like mucus. So mucus plugs are known to cause fusion of the cholesterol which leads to the formation of stones within the gallbladder. Other than that, increased glycoprotein as well as infection can cause gallbladder stone. Supersaturated bile. Supersaturated bile means the cholesterol is so much in excess within the bile in the gallbladder that it precipitates to form stone. So as the age advances, there is more chances of this happening. Usually seen in females, can be genetic, usually seen in obesity as well as diet rich in fat. So that is why one of the common anecdotes that are referred to when we talk about cholelithiasis is fat, fertile, female, 40. That is usually seen in female patients, usually seen in slightly obese individuals, usually seen in the fertile age group where they take OCPs, which can be one of the factors causing gallbladder stone formation because of concentration of cholesterol. So coming to the individual pathologies, cholesterol stones, pigment stones or mixed stones. These are the three types of stones that are formed in the gallbladder. Cholesterol stone, yes, they have pure cholesterol. Pigment stones are small black or greenish black multiple stones, and mixed stones which have both cholesterol as well as pigment stones. They can contain also calcium salts of phosphate, carbonate, palmitate stones. They are multiple faceted. First, coming to cholesterol stones. Normally, cholesterol is insoluble in water. So it is insoluble in water. To keep it in that soluble state so that it does not precipitate into stones, two important parts are there. So two important things take part. One is phospholipids and second one is bile acids. These phospholipids form micelles. And these micelles are responsible for keeping the cholesterol in the soluble form so that they don't precipitate into stones. So, decreased phospholipids will lead to decreased formation of micelles, which in turn will cause precipitation of the cholesterol into stones. Second one is bile acids. Bile acids again are responsible for keeping the cholesterol in the soluble form. Anything that causes decreased bile acids like ileal resection surgeries which causes decreased bile absorption, that can lead to the formation of supersaturated bile leading to cholesterol crystallization leading to stone formation. So because of all these reasons, bile is supersaturated with cholesterol or bile acid concentrations are low, leads to the unstable unilamellar phospholipid vesicle formation, which in turn causes the cholesterol crystals to nucleate and stones may form. Any condition which either increases the cholesterol secretion in the bile or reduces the bile salt concentration causes cholesterol stone formation. And here comes old age, oral contraceptive pills, obesity, low fibrate. which increases cholesterol secretion. Fat, fertile female 40. Estrogen, ileal resection, cholestyramine, they reduce the bile salt concentration. Again, it leads to the formation of cholesterol stones. So these factors cause increase in cholesterol secretion. These factors cause reduce in the bile salt concentration. So old age, oral contraceptive pills, obesity, clofibrate. So they cause increased cholesterol secretion. Estrogen, ileal resection, cholestyramine, they reduce bile salt concentration. Two factors which are protective, which prevent the formation of stones is quinodeoxycholic acid as well as ursodeoxycholic acid stones. Next, coming to pigment stones. So these pigment stones are stones that contain less than 30% of cholesterol. If it is more, we would have called them as cholesterol stones, and they are further divided into black stones and brown stones. These black stones are associated with hemolysis. The brown stones are usually seen in individuals who have stents or parasitic infections. So black stones, they contain insoluble bilirubin pigment plus calcium phosphate or calcium bicarbonate. Brown stones contain calcium bilirubinate, palmitate, stearate plus cholesterol. So there is deconjugation of bilirubin diglucuronide by bacterial beta-glucuronidase, which in turn can lead to the formation of stones. So what are the clinical features? Now the stones can be in the gallbladder or it can be in the common bile duct. So when the stones are in the gallbladder, many times they can be asymptomatic. They can present with biliary colic, especially when the stone is stuck at the neck of the gallbladder, where the opening of the cystic duct. So that time patient will have severe pain when the gallbladder is trying to contract and send the bile into the cystic duct against the stone. This pain can be spasmodic pain, severe, present in the right upper quadrant, that is the right hypochondrium as well as the epigastrium, and it can radiate to the chest and shoulder and back. It is associated with dyspepsia, flatulence and intolerance to fatty food. This is stone in the gallbladder. If the stone has gone from the gallbladder into the cystic duct and into the common bile duct, then these are called as secondary CBD stones. It can lead to cholangitis, obstruction to the flow of bile in the CBD, stasis of bile, infection, cholangitis. It can also lead to pancreatitis, Mersey syndrome, where a large stone in the cystic duct is compressing on the common hepatic duct or common bile duct, causing stasis. And in the intestine, it can cause gallstone ileus. Suppose the stone is large in the gallbladder. From the gallbladder, it has caused inflammation of the gallbladder wall, and this inflamed gallbladder wall is stuck to the duodenal wall. The duodenal wall also now is inflamed. It leads to the formation of fistula between the gallbladder and the duodenum. Now the stone from the gallbladder goes through this fistulous tract into the duodenum, goes into the jejunum, goes into the distal part of the ileum. There it obstructs the narrow lumen of the ileum, causing features of intestinal obstruction, and that is known as gallstone ileus. What are the investigations? Anything related to the biliary tract, the first thing that we think of is LFT, especially if here the stone has gone into the common bile duct, what we know as Cholelithiasis. Then the bilirubin will be elevated and the total bilirubin, direct bilirubin, will also be elevated. That is obstructive jaundice. Total WBC count can be elevated if there is acute cholecystitis. Otherwise, it will be normal. In a asymptomatic gallstone, the LFT can be normal. Ultrasound abdomen will show the presence of stones in the gallbladder. X-ray abdomen might help to locate stones if they are large or even multiple small stones in the gallbladder. CT scan mainly to evaluate the gallbladder as well as the biliary tree to look for stones in both CBD as well as the gallbladder. What is the treatment? Asymptomatic gallbladder with cholelithiasis will not require surgery unless the patient is diabetic, the patient is suffering from congenital hemolytic anemia. Patients who are undergoing bariatric surgery for morbid obesity. Because diabetic patient more prone for infection, patients who are undergoing bariatric surgery later, you may not have access to the gallbladder if the patient develops cholelithiasis and congenital hemolytic anemia. Symptomatic gallstones, cholecystectomy is done, and if there is infection, we are talking about asymptomatic gallbladder. When will you operate? Normally, you do not operate, but you will operate in those special circumstances. Now, we are talking about symptomatic gallbladder. That is, patient has developed inflammation of the gallbladder secondary to the stone. So, acute cholecystitis. So, initially, when the patient develops acute cholecystitis, non-operative treatment is based on 4 principles. Keep the patient nil per oral and start IV fluid. So, nil per oral, IV fluid administration until the pain resolves. Then analgesics are also given, and antibiotics, usually cephalosporin, that is cefazolin, cefuroxime, ciprofloxacin is given. The idea behind doing all this, that is keep the patient nil per oral, start IV fluids, analgesics, antibiotics, see that the temperature pulse rate is normal, is so that the inflammation slowly settles down, and then a cholecystectomy, whether laparoscopic or open cholecystectomy, can be done after 6 weeks once the inflammation has settled down. If the surgery is done, it can be done during that acute inflammatory phase, but due to dense sedation, the gallbladder will be friable, the surrounding structures will be friable, so the surgery might be difficult. So that is why a cholecystectomy, after the initial non-operative management, cholecystectomy is usually planned after 6 weeks. The ideal time to operate a patient who has come with acute cholecystitis is within 2 days or after 6 weeks. Anything in between is a difficult surgery. It is not impossible, it just becomes very difficult. Operative treatment, the cholecystectomy can be either done laparoscopically or open. So, to summarize the cholelithiasis, it is the most common biliary pathology. It can be cholesterol, pigment, or mixed stones. Clinical features: patient will present with biliary colic, especially if the stone is at the neck of the gallbladder or it has gone into the common bile duct. Ultrasound, abdomen, and LFT are important investigations, and the treatment in a case of symptomatic gallstones is laparoscopic or open cholecystectomy. So this in brief is cholelithiasis.